Hello, I'm Dr. Jason Worley, an orthopedic surgeon at Rocky View Hospital in Calgary and the medical director of the Bone and Joint Health Strategic Clinical Network. Albertans truly deserve the best possible health care rooted by scientific evidence and fueled by compassion. Alberta Health Services is on a mission to provide a patient-focused, high-quality health system that is accessible and sustainable for all Albertans. They created 16 specialized agents of change, known as the Strategic Clinical Networks, to tackle the challenges in specific areas of health and to work towards improving health outcomes and patient experience. Among the 16 networks, the Bone and Joint Health Strategic Clinical Network helps transform the delivery and quality of bone and joint care. They work in collaboration with the Alberta Bone and Joint Health Institute, a non-profit organization that leads bone and joint health knowledge and research in Alberta. This organization offers project management, performance measurement, data analysis, and knowledge translation services to various institutions, hospitals, and clinics. In 2018, Alberta Health Services identified shared decision-making as a high priority in healthcare for provincial implementation, and they created a team known as Improving Health Outcomes Together, in short IHOT, to champion this project. This team approached the Alberta Bone and Joint Health Institute to implement shared decision-making in their long-running, successful hip and knee osteoarthritis program. I'm here today to talk about shared decision-making and how it can be better implemented in your everyday practice. We will discuss how to apply the steps in shared decision-making, employ some of the tips and tricks in the paper package, and navigate through the fact sheet that you can provide to your patients. The elective nature of total joint arthroplasty creates an opportunity for an active discussion between the patient and their physician on the timing and appropriateness of surgery for the individual living with hip or knee pain. Shared decision-making raises the following questions. Is there sufficient information given to the individual about the treatment options for their osteoarthritis? Is the patient supported in making an informed decision based on their own personal preferences and values? Has the patient's satisfaction with their final decision improved? This is a collaborative process. The consultation between patient and physician is central to shared decision-making. It is where all treatment options are described and discussed, trustworthy information about the risks and benefits are reviewed, and expected outcomes of each treatment are shared, and most importantly, a trust is established. Ultimately, a decision is made as a result of our collaboration with the patient. Shared decision-making suggests that informed preferences, which means what matters most to patients and families based on the choices presented, should play a major role in the decision-making processes. It represents an important shift in the roles of both patients and physicians. Sharing decisions signals an end to the view that doctors always know best, and the end to making medical recommendations without considering how they might align with what matters to patients. With shared decision-making, and through discussion, patients are asked to play an active role in the decision-making process by listening to the best evidence and information about their treatment options, and then considering how these options fit with their own values, goals, and current life situation. We do not believe future generations of patients will tolerate important decisions being made without them understanding the key trade-offs between the harms and benefits of these interventions. Ultimately, using shared decision-making allows for patients to have their preferences heard and make an informed decision for themselves as well as for their family and support systems. We know from our hip and knee surgeons in Alberta that many elements of shared decision-making are already happening in their clinics and consultations. The purpose of the next few minutes is to provide guidance for enhancing your communication skills around shared decision-making and to share some tools, tips, and tricks that will help with the provincial adoption of this patient-centered approach to decision-making. As a surgeon who has seen thousands of patients with hip and knee osteoarthritis, I feel confident in the medical recommendations and decisions made with my patients. But I also have to consider that my professional opinion may vary from my patients' preferences. To practice shared decision-making is to practice allowing space and time for information sharing based on the evidence and supporting patients to deliberate and share their preferences as we build their treatment plan together. The idea of shared decision-making has been promoted by healthcare policymakers across North America, including Alberta Health Services leadership team. However, adoption of shared decision-making has been slow. Practical problems are often noted as barriers, such as a lack of time in a consultation, difficulty envisioning fitting a new process into existing workflow, and scarce information designed for patient use. Some physicians have reported that the communication style of shared decision-making is difficult to adopt. These concerns have been explored by researchers, and the results are encouraging. Orthopedic consultations were shown to have no increase in length of time when using shared decision-making. Furthermore, when a tool exists to show treatment options in a digestible format for patients, physicians reported satisfaction with the change in their approach to reaching a medical decision with their patient. Part of the toolkit you'll see later in this video includes such a tool with information in a digestible format. We've called the tool a treatment comparison chart, and it includes Alberta data that can inform a patient's understanding of the risks and benefits of the treatment options for osteoarthritis of the hip and knee. Building a good relationship with the patient is key to achieving shared decision-making. The shared decision-making approach also takes into account the extent to which a patient wants to be involved in making the decision. There are different levels of patient comfort in making a medical decision. For example, some patients may wish to be informed about their treatment options, but may not want to shoulder the full responsibility for the decision. A practical model for implementation that we would like to use in Alberta is called the 3-talk model of shared decision-making. This model was developed by Glyn Elwyn. Let's talk through these 3 elements of shared decision-making implementation. The first element is called team talk. This is where we have an opportunity to open the conversation with our patients by explaining that we'd like to collaborate together to make an informed decision that suits the patient best. At this point, we can also explain that we'd like to help them base their decision on what we've learned from Albertans who have been cared for in the past. This is where we may learn how much of the responsibility the patient wishes to take on when it comes to making a medical decision in our office. We may see patients reluctant to make that final decision, or alternately, we may see them eager to be in the driver's seat, with us acting more like a guide. The second element of shared decision-making implementation is called option talk. This is where we present the alternatives for treatment options for patients with osteoarthritis, and we communicate the risks and benefits of these options through comparisons. At this point, we are just laying out the options, and we are not steering our patients to choose a specific option. You will see in your toolkit the comparison chart that gives accurate data for the risks and benefits of choosing to have surgery or choosing other treatment options. The final element of shared decision-making is called decision talk. This is where patients are given time to deliberate their options and to establish their preference. This is where the patient considers their own values, beliefs, and life circumstances and relates them to the options before them. Some questions that may help patients decide include: what considerations do you need to keep in mind as it relates to these treatment options? What matters most to you as you decide? Can I answer any further questions about the treatment options that might help you get to a decision that suits you best? The Shared Decision-Making Clinic Toolkit contains 3 main elements of information. The first is a 4-page tips and tricks guideline to strengthen your shared decision-making skills. This will outline the purpose and advantages of employing shared decision-making at your clinic, as well as guide you through the steps in team talk, option talk, and decision talk. The package will also include 3 posters that you can display inside the clinic and office to alert patients about shared decision-making. Lastly, a 1-page patient-friendly handout will be provided with more evidence and treatment options. Thank you for joining me today to learn more about the shared decision-making model and for implementing the process in your everyday practice and clinics. We as orthopedic practitioners should be very proud of leading patient-centered care and for being the champions of Alberta change yet again. For more information, please check out the Alberta Health Services website.